Alright, now we're coming to the last leg, and I know it's been quite long so far, but what we'll focus on now is the treatment of acromegaly. And basically, like you said, we go back to this diagram, and you can see here the growth hormone releasing hormone that has a positive effect, and the somatostatin has a negative effect. So essentially what we want to do is enhance the effect of somatostatin, which would bring about growth hormone being inhibited. Or like other sort of treatments, we antagonize the effect of growth hormone. And so, like we said, how it works on the JAK-STAT pathway, we block that receptor. And when we block that JAK-STAT receptor with a growth hormone receptor antagonist, it means none of its products, such as somatidin, which is also known as like insulin growth factor like hormone, all of those factors won't be able to be produced, and it won't cause the increased blood glucose, and won't lead to the diabetes, it won't lead to the organomegaly and things like that. So they're the sort of medicinal products we're looking at, and you can actually see that down here. So I've written that here. I haven't written any brand names because they'll be different between all the countries, but you can see here, this is the pegvisomint, and this is the growth receptor antagonist, and it's going to prevent the growth hormone binding to the receptor. The others are the otides, if you like, easy to remember, octreotide and lanreotide, and these are somatostatin analogues. So analogues just means similar to, if you like, and they'll be enhancing the activity of the somatostatins that way. The other thing is the dopamine agonists are sometimes used to inhibit growth hormone secretion. Now, there's no sort of clear mechanism that's been stated in a lot of textbooks, but my understanding is that if you think of prolactin and growth hormone, they're very similar in structure, and they both act on JAK-STAT pathways. Now, the same way as growth hormone, somatostatin inhibits growth hormone, dopamine inhibits prolactin. And so because the somatostatin and dopamine are similar in structure, you can have sort of the dopamine inhibiting a bit of the growth hormone as well, and that's potentially why you can use dopamine agonists to inhibit growth hormone secretion. Now, the differences between acromegaly and bromocriptine is one mostly due to sort of patient compliance, because the bromocriptine here, you have to dose this twice or 3 times a day, whereas acromegaly, you only have to dose it once or twice a week. So this is a long-acting dopamine agonist. And now when I say dopamine agonist, it's important to emphasize it's dopamine 2 receptor, so it's specifically for dopamine 2 receptors. The other sort of treatment options available for these people are surgery. So there's transsphenoidal surgery. Now, if you remember what we mentioned about before, how this pituitary gland was housed inside the sella turcica, which is part of the sphenoid bone. And we've got a picture down here. So this is the pituitary gland right there, and this is the sphenoid bone, the sphenoid sinus here. So that what they would actually do is go through here, drill through there to get to the anterior pituitary. So, and this is another reminder of the embryology, how the anterior pituitary was that extension of the mouth there, so it was the upward growth. So that's how they would go about having surgery, and resecting parts of the anterior pituitary that were tumor-like, and that way they can also decrease the compression against the optic chiasm there. So they'll often do surgery if there's mass effects. So the mass effects are the things not only just related to the optic chiasm, but sometimes it can cause the stretching of dura, which can cause things like headaches. Sometimes people suffer from epilepsy, rarely, if you've got these kind of expansion things. The other last option is basically just radiation, and that's aimed to sort of, again, obliterate the gland. Sometimes excessive radiation will actually lead to hypopituitarism, which means that all the anterior pituitary cells will sort of cease to function secreting hormones, and therefore you'll have to give the patient sort of lifelong hormone therapies, but that's one of the side effects of the radiation. Now this is sort of one of my first ever videos, so if you have any sort of comments on it, what you would like to see specifically medically related, please let me know in the comment box, and hopefully if I have time I can go about making some more videos or even answering some of your questions. I hope you found this useful.